Bismillah ar-Rahman ar-Rahim. I am Dr. Muhammad Talat, Assistant Professor of Radiology at Cairo University. Welcome to ERO, Easy Radiology Approach. Today, inshallah, we have the third part, 3B, of our course, MRI of the prostate. In the last sessions, we discussed the standard MRI protocol and the second part, MRI anatomy of the prostate. The third part, we started to focus on the peripheral zone lesions on part 3A. Today, inshallah, we will focus on the transitional zone, part 3B. And we will end our course by our demonstrative cases or practical cases. Our sources, as we discussed before, prostate imaging reporting and data system. Also, we will share some slides from radiology assistant, amazing slides. In the last session, we discussed the RADS version 2.1, and we discussed that RADS 1, very low probability of prostatic cancer. RADS 2, low probability. RADS 3, intermediate or equivocal. RADS 4, high probability. RADS 5, very high probability of prostatic cancer. Also, we should know that 70 to 75% of the prostatic cancer originates from the peripheral zone, while 20 to 25% of the prostatic cancers originate from the transition zone. Prostatic cancer, which originates from the central zone, most likely spread from either peripheral zone or transition zone. Also, it's very rare to see prostatic cancer originating from the fibromuscular stroma. In the last session, we discussed the peripheral zone, and we agreed together that the diffusion with image is a dominant sequence. RADS obey the orders of the diffusion with image. As we discussed that every sequence, we will give the lesion scores from 1 to 5. This is a scale from 1 to 5 for the diffusion with image and the T2 and the dynamic contrast enhancement. And according to these scores, we will calculate or we will estimate the RADS classification. Today, in our transitional zone, the leader here is the T2 with image, not the diffusion. So the RADS will obey the orders of the T2 with image. If we have any lesion in the transitional zone, we will give it score from 1 to 5. And to be clear from now, score 1 and 2, most likely this is nodules. Score 3, this one like smearing or charcoal in shape. Score 4 and 5, mass, lentiform-like mass, or speculated mass-like lesion. So the morphology is very important. Besides the T2 score, this one can help you to classify the RADS assessment, as we will discuss later on. So the leader here, again, if we need to assess the transitional zone lesions, the T2 with image is the leader. Regardless, the dynamic contrast enhancement study, as you can see here, it has no rule, while the diffusion is very important in these classifications regarding score 2 and score 3 T2 with image. For example, if we have T2 score, T2 with image, we will see the diffusion with image either more than or equal 3 RADS 2, more than or equal 4 RADS 3. If we have T2 score 3, according to the diffusion, if it is less than or equal 4 RADS 3, if it is 5 RADS 4. So we will discuss all of these in details now. Before going to describe in details how to give the lesion scores on T2 weighted image, we would like to review some important tips here. In benign prostatic hyperplasia, we have either glandular hyperplasia or stromal hyperplasia. So benign prostatic hyperplasia consists of glandular hyperplasia and stromal hyperplasia. Glandular hyperplasia can be presented by nodules. Stromal hyperplasia can be presented by hypertrophied prostatic tissues in between the nodules. So if we need to draw a diagram for the transition zone and another diagram for the peripheral zone, if we have nodules, and these nodules with sharply marginated outline, as you can see here, this is a nodule with sharply marginated, well-capsulated outline. So this one, we can score this one as score 1. I'm talking on T2 weighted images. So we are now scoring the lesions on T2 weight images. So this is score 1. Sometimes we have the same nodule with small cystic changes inside the nodules, displaying bright T2 signal on the diffusion weight images. This is also score 1. So this is the typical features of the prostatic nodules. We have another possibilities. Sometimes we have the lesion with partially encapsulated margin, as you can see here, or mostly capsulated margin. Sometimes you can see the nodule without any capsulation, but it is well defined, but without any capsule. Sometimes if you have the intervening tissue between the nodules is dark on T2 with images. So we have another possibilities of score 2. This is score 2. This is score 2. And this is score 2 as well. So if we have partially encapsulated nodule, if we have a nodule without any capsule, if the intervening tissue in between the two nodules is dark on T2 with images, this one is score 2. Take care of this point. I said darker than the background. So if we have this lesion darker than the background, if it is similar to the background, homogeneous hypointense, so we don't have any lesions. But if we have intervening tissue in between the two nodules and this patchy area or this tissue displays lower signal intensity as compared to the background on the T2 with image, so it is considered as score 2. If we have patchy area, sometimes call it charcoal area, ill-defined charcoal area, different from the background and away from the nodules, this one is considered as score 3 on the T2 with images. If we have lesion or mass-like lesion, and this lesion ill-defined, it doesn't look like a nodule, but it is lentiform mass lesion, and it is less than 1.5 centimeter. So this one is score 4. If we have a smaller lesion or a small lesion, but with invasive behavior, like it can invade the surgical capsule. This is the surgical capsule between the transition zone and the peripheral zone. Sometimes we call it as a pseudo capsule. If the lesion breaching the capsule, so this one is invasive in nature, so this one is score 5. If we have a larger lesion, more than 1.5 centimeter, similar to this one, but it is larger than 1.5 centimeter, so this one also score 5. Those are the scores on T2 with MRs. My last step here, sometimes typical nodule, something like this one, and making a bulging of the pseudocapsule. This one is a benign feature. Take care of this point. I'm talking about nodule, typical nodule with well circumscribed margin, and this one is projecting into the peripheral zone, sometimes bulging of the prostatic capsule itself, but it is benign features from the start, so this one is considered as a benign features. I'm talking about lentiform mass, and this one, if it is larger than 1.5 centimeter, so it is score 5. If it is small lesion but crossing the capsule or invading the fibromuscular stroma, for example, or invading any of the surrounding structures, so this one score 5. Another important point here, the typical nodules, the typical benign nodules on the benign prostatic hyperplasia can display different signal intensities, can show different diffusion restriction, can show different contrast enhancement on the dynamic contrast study. So the typical nodule can display low signal intensity on T2 with MRs. Also, if it is mucin retention nodule, it can display bright T2 signal on the T2 with MRs. So take care of this point. Nodules of the benign prostatic hyperplasia can display any signal intensity. Tumors or transitional zone tumors or malignant features, these nodules display low signal intensity on the T2 weighted MRs. It is totally different from the background with ill-defined margin. Any ill-defined margin nodule, take care of this point. Any ill-defined patchy area or charcoal area, as you can see here, take care of this point. Any mass-like lesion, lentiform, non-capsulated mass, different from the nodules of the benign prostatic hyperplasia, as you can see here. All of these features that you can keep it in your mind and review the other sequences as we will see together in the next slides. So again, let's classify or let's give the score for the transitional zone lesions according to the T2 with MRs. As we said, score 1, typical appearing nodule, completely encapsulated nodules. Score 2, partially encapsulated or mostly encapsulated nodule, or nodule without encapsulation, as we said. Also, if we have homogeneous, mildly hypointense area between the nodules. Regarding score 4 in the T2 with MRs, lentiform mass or non-circumscribed homogeneous mass shorter than 1.5 centimeter. If we have the same criteria as 4, but it is larger or equal 1.5 centimeter, or if we have a small lesion with definite extra prostatic extension or invasive behavior, so we are now in score 5. Score 3, any other features not typical for score 1 or 2 or 4 or 5. Heterogeneous area of signal intensity with obscured margin, different from the background. Take care of this point. Different from the background. For me, in the reporting, this one, I will not report this one because this one is typical. Starting from here, I will score and I will add in my report either score 2, 3, 4, and 5. benign prostatic hyperplasia, you will find multiple nodules, and these nodules even sometimes typical nodules, but give diffusion restriction, and also sometimes gives positive data in the dynamic contrast enhancement. So therefore, we are depending on the T2 with image, not the diffusion with image, in our scoring to estimate the PIRADS. Regarding the PIRADS assessment of the diffusion with image, we have score from 1 to 5 as usual. It is the same as we discussed in the last session because the PIRADS assessment of the diffusion with image is similar for the peripheral zone and transition zone. So we will not go more deep. If you want to review this one, please watch the last video. But I would like to highlight that score 3, it is markedly hypointense on ADC or take care of or not and markedly hyperintense signal on the diffusion with image, on the high p-value diffusion with image, not both. Another possibility is that if we have focal area of hypointense on ADC and or focal hyperintense, so it is not markedly hypointense, not markedly hyperintense signal. This one can be and or. Score 4, focal, markedly hypointense on ADC and markedly hyperintense on high p-value. So take care of the difference between score 3 and score 4. Score 4 shorter than 1.5 centimeter, score 5 greater than 1.5 centimeter, or definite extra prostatic extension or invasive behavior. Regarding the PIRADS assessment of the dynamic contrast enhancement, as we discussed in the last session, if we have, this is the curve features of the malignant lesion. This is a malignant lesion, focal, rapid, quick, rapid, and rapid washout. This is the classic curve for the malignant focal lesion. Sometimes you have plateau. This is equivocal. Sometimes you have progressively increasing in the signal intensity without washout. This is the benign features. So this is a malignant feature, focal, early contrast enhancement, and at the same time corresponding to suspicious lesion on the T2 in the transition zone, or the diffusion with image if the lesion is located at the peripheral zone. So let's review again with our amazing figures from the radiology assessment. If we have nodules sharply marginated, even with some cystic changes, this one score 1 according to the T2 with image. Regardless of the diffusion with image, it will be PIRADS 1. If we have this lesion or this nodule without any margin, if it is partially encapsulated, or the intervening tissue in between hypointense as compared to the background of the transition zone, so we have T2 score 2. According to the diffusion, if it is less than or equal 3, so we have PIRADS 2. If it is more than or equal 4, according to the diffusion score, so PIRADS 3. If we have this lesion, ill-defined lesion, smear-like or ill-defined lesion, this one is T2 score 3. So according to the diffusion, if it is below or equal 4, according to the score on diffusion with image, so this is PIRADS 3. If it is diffusion with image 5 and 4, the difference between this and this one is a size. If it is larger than 1.5 centimeter, or if it shows extra prostatic extension, so this one will be PIRADS 4. If we have score 4, if we have mesh-like lesion, and this mesh-like lesion on the T2 with image score 4, this one will be by RADS 4. If it is score 5 on the T2 with image, it will be by RADS 5. So this is the guidelines. This is by RADS version 2.1. Before reviewing one of our practical cases today, I would like to review some important tips. Hemorrhage, cyst, calcifications. Those are common findings in reporting of MRI prostate. Hemorrhage can be occurred after biopsy trial. So this is the value of the T2, T1 with image. If we have high T1 signal corresponding to low T2 signal or high T2 signal, this one can be related to prior biopsy procedure. So we have hemorrhagic focus. If we have cystic lesion, and it is common in the transition zone inside the nodules, it will show dark signal on the T1 and bright signal on the T2 with image. Calcifications, it will show dark signal on T1 and dark signal on T2 with image. So this is the value to take T1 sequence within our MRI protocol. So according to the age of the hemorrhage or hematoma, it will give us the signal, different signal intensities, cysts, as we know, and calcifications. We will review some important terms. It's very important to know how to use these terms. If the lesion, for example, this is the capsule of the prostate, and this is the lesion. So the lesion here, aputs. Aputs mean touch. So the lesion touches the prostatic capsule. Sometimes the lesion like this one, and the capsule appears like this one. So we have here bulges of the capsule. This one is very important. It is totally different from touch the capsule. Here the capsule is deformed by the message. If we have also tumor capsule attachment more than 1 centimeter, we can suggest microcapsular invasion. Take care of this point. If we have the attachment site between the tumor and the capsule 1 centimeter or more, there is high possibility of microcapsular invasion, and you should write this one in your report. Sometimes the tumor or the mass lesion can induce mass effect on the surrounding structures, on the seminal vesicles, on the neurovascular bundles, or any other surrounding tissues. Sometimes also the tumor can invade the surrounding structures. Take care of this one. Mass effect means displacement without invasion. Invasion means that the tumor breaches the capsule and invades the surrounding structures. The tumor can invade the fibromuscular stroma, breaches the capsule, sometimes can invade the seminal vesicles, seminal vesicle invasion, SVI. Also, the tumor can invade the neurovascular bundles. We have 3 features for neurovascular bundle invasion: asymmetry between right side and left side neurovascular bundle, loss of the fat planes surrounding the neurovascular bundles. The fat plane or the fat surrounding the neurovascular bundle displays high T1 signal. If we have loss of this high T1 signal, neurovascular bundle invasion can be suggested. Sometimes you can see direct invasion towards the neurovascular bundle. So we have, these are features of neurovascular bundle invasion. We have two important angles, recto-prostatic angle and the prostate seminal vesical angle. Both of these angles should be reviewed during your report. Invasion of the bladder neck, one of the most important structures. Invasion of the membranous urethra inside the prostate. If we have, also you should mention clearly that do you have any extra prostatic extension or not in your report, as we will see in our report. So let's review again our last case. We discussed in the last time that we have on the diffusion weight image 1400 B value, we have a small lesion of bright signal intensity on the diffusion weight image, and we have on the corresponding ADC black hole. So this one is considered as diffusion with image score 4 because it is less than 1.5 centimeter. And we have another lesion at the apical zone, right side of the apical zone, larger lesion, black hole on the ADC map. So this one is considered as diffusion with image score 5. So we have PIRETS 5 on the apical zone and PIRETS 4 on the mid gland. On the T2 with image, as you can see here, this is a mass lesion displaying low T2 signal. Also, we have another mass lesion on the apical zone displaying low T2 signal. On the diffusion with image, as you can see here, on the early phase of the dynamic, the lesion shows intense rapid contrast enhancement as compared to the rest of the gland with rapid washout, as you can see here, rapid washout of the contrast media. This is a malignant feature. Also, the other lesion, look for the other lesion here. It is clearly defined that we have intense contrast enhancement on the early phase of the dynamic contrast with washout. So we have two lesions with all malignant features. Let's focus on the transitional zone. As you can see on the transitional zone, you will find many nodules, and these nodules show cystic changes inside, displaying bright T2 signal. Look for this nodule, for example. This is nodule with sharply defined margin, so it is score 1 on T2 with image. If we go to the base of the gland, you will find two lesions, two nodular lesions, this one and this one. These two nodules didn't show well circumscribed margins. It looks like nodules, but without well capsulated margin. So we should review our diffusion with image. You will find on the diffusion with image markedly hyperintense, markedly hypointense on the ADC map. So this one, T2 score 2, but the diffusion with image, it is 4. So according to the T2 score 2, the diffusion with image score 4. So both of them can give me PIRETS 3. Okay. We don't have any seminal vesicle invasion. Look for this is the post seminal vesicles, bright T2 signal, homogeneous. We also should review the surrounding structures, and also you should review the T1 with image. Look for the neurovascular bundle here. This is a normal appearance. Look for the fat inside. It is very clear. Very clear. This is the fat and this is the neurovascular bundle. So we don't have any neurovascular bundle invasion. We don't have any seminal vascular invasion. Let's review again the lesion located at the apical zone. This is a lesion and this is the prostatic capsule. So the lesion or the tumor capsule interface more than 1 centimeter. So we have a possibility of microcapsular invasion. Microcapsular invasion. It is not macrocapsular invasion because we don't have gross tumor extension beyond the capsule. We don't have something like this. So it is microcapsular invasion, a possibility of microcapsular invasion. Also, we should review for any lymph node spread. We should review the pelvic organs. We should review the bones for any osseous deposits, especially on T1 with image. So let's go to our report. Really, I reviewed many forms of prostate MRI reports. In my opinion, I suggest this one. I think it is the most informative report. Our report includes the history and indication. For example, elevated serum prostatic specific antigen, and this is a value. Also, we should enumerate the technique, our technique. This is the main sequences that we used in our exam. If we have any old studies, we should compare to the previous studies. We don't have any previous study in our case. And we will go to the main core or the most important core in our report, the findings. Our findings will be divided into few paragraphs. The first will be the size of the prostate. We will measure the size of the prostate in 3 dimensions and multiply these 3 dimensions times 0.52. We will get the prostatic volume. For example, here is 62.8 cubic centimeter. According to the volume of the prostate and the PSA level, as you can see here, the PSA level is 14.2. So we will divide 14.2 divided over 62.8. This is the prostatic volume, and this is the PSA level. We will get the PSA density. So this one will be the PSA density. In our case, it is 0.22. What is the value of the PSA density? According to the many articles, the cutoff value of the PSA density is 0.15, 0.15. If we have the readings below this figure, low risk patient. If it is higher than this value, so we have high risk patient. And this one is very important, as we discussed in the last session. If we have by RADS 3 intermediate or equivocal lesion and we have PSA density above 0.15, biopsy may be indicated in many institutes. Okay. Also, in this section, we will comment on the quality of the exam. In our case, it's optimum. We don't have any distortion of any anatomical structures. Hemorrhage, we don't have any hemorrhagic features. We don't have any high T1 signal. Peripheral zone, it is hyperintense T2 signal with 2 focal lesions we will describe below. The transition zone, it is moderate heterogeneous, consistent with prostatic hyperplasia, but we have also focal finding as below. Regarding the focal findings, we will enumerate the focal findings. For example, lesion number 1, The most important lesion is the one located at the right apex of the peripheral zone, PZA, PZBL, anterior and posterolateral segment. This one is PZA, anterior, and this one is posterolateral segments located at the apex of the prostate on the right side, and the size of the lesion 1.9 times 1.3 centimeter. Sometimes, or some authors suggest that you should measure the lesion on the 3 dimensions and measure the volume, but I think this one can be done at least. The diffusion width image, we can give a score for this lesion: markedly hyperintense, markedly hypointense. So this one is either category 4 or 5 according to the diffusion score. This lesion is greater than 1.5 centimeters, so we categorize this one according to the diffusion score 5. On the T2 with image, it is ill-defined lesion, homogeneous, moderately hypointense, larger than 1.5 centimeters, so score 5. Dynamic contrast enhancement positive. Prostate margin, the lesion abuts and bulges the prostatic margin. So overall category. So our overall category is Pyrite 5 for this larger lesion. For the smaller lesion, it is located at the mid gland, left side, peripheral zone. This is the size of the lesion, T2 homogeneous hypointense. So this one is score 4 according to the T2, and also score 4 according to the diffusion, markedly hyperintense and markedly hypointense. Positive on dynamic contrast enhancement study. We don't have any gross extraprostatic extension. So the Pyrite score here is 4. Now we will shift to the transition zone. We have 2 lesions, lesions 3 and 4. These lesions located at the right and left side mid-gland transition zone, TZA and TZB on either side. The size of the left side lesion is larger in size, 1.3 times 0.9 centimeter. These nodules are non-capsulated homogeneous nodules. So it is nodules, but without any capsule. So this one is score 2. On the diffusion width image, these nodules display markedly hyperintense signal on high p-value diffusion and markedly hypointense on ADC. So this one is category 4 because this lesions is less than 1.5 centimeter. So according to these scores, score 2 on the T2 with image and score 4 on the diffusion with image. So we have Pyrite 3, as we discussed before. Regarding the dynamic contrast enhancement, it is positive. But regarding the dynamic contrast enhancement, as we said before, it has no role on the transition zone. Prostate margin is clear, so we have Pyrite 3. We should mention all of these surrounding structures. Neurovascular bundles not involved, seminal viscus not involved. We don't have any lymph node spread. The bones are free. Other pelvic organs are normal. If we have one of these positive findings, you should mention this one in your description regarding the lesions, either located on the peripheral zone or transition zone. For example, if we have the lesion on the peripheral zone invading the neurovascular bundle, you will describe this one on the description of the lesion, and you will not mention this one again in this area. So in our conclusion, we have highly suspicious peripheral zone 2 lesions. The larger lesion located at the right apical peripheral zone with possible microvascular invasion, and the left mid-gland peripheral zone smaller lesion with no extra prostatic extension. So we have Pyrite 5 and Pyrite 4. These lesions are indicated for biopsy and histopathological collation. We have another two lesions located at the right and left side of the transitional zone with no extra prostatic extension. This one is by RADS 3. I hope you enjoyed our lectures or our sessions for MRI prostate. Inshallah, next session will be on our practical cases, our demonstrative cases. If you want or if you are interested to interact with us, please join us on our WhatsApp group to allow me to select you and to join me on our next sessions. Thank you so much.